Good morning, and welcome to another interesting case. My name is Jamison Hake, and I'm a PMR PGY4. Today we'll be discussing an EMG case that I completed in the outpatient setting with Dr. Andery a few months ago. As a part of this case review, I would like to review some principles of anatomy and technical details with nerve conduction studies. I hope you enjoy the case this morning. This is a relatively healthy 28-year-old obese male with a history of hypertension who presented for a left lower extremity EMG. The patient works as a laborer and reports that over the past month he has had numbness and tingling over the lateral aspect of the left lower extremity, particularly over the left lower leg. He reports that this pain is most bothersome at night and denies any weakness in the left lower extremity. He also denies any numbness and tingling in the contralateral leg or symptoms in the hands. He also denies any pain in the back. He reported that he does not have any difficulty with gait or any weakness. He reports that with his job, he spends an increased amount of time on his knees and does some repetitive bending and twisting at work. He reports that an unknown vascular study was completed at his PCP and that was normal. A physical exam was completed with manual muscle testing, which included hip flexion, knee extension, dorsiflexion at the ankle, as well as inversion and eversion, toe flexion and EHL strength. All of these manual muscle testings were completed bilaterally and were normal. Patient also had normal reflexes and downgoing toes bilaterally. A brief sensory examination was completed of the left lower extremity, and the patient noted that there was a slight difference in light sensation compared to the lateral and medial aspect of the left lower leg. Following the history and physical examination, our electrodiagnostic differential diagnosis points most directly to left fibular neuropathy at the fibular head. Other possible diagnoses include L5 to S1, radiculopathy on the left, peripheral polyneuropathy, lumbosacral plexopathy, and sciatic neuropathy. Because fibular neuropathy is our leading diagnosis at this point, let's review some basics regarding fibular nerve anatomy, patient presentation, etiology, and electrodiagnostic workup. Because fibular neuropathy is our leading diagnosis, let's get to know the anatomy of the fibular nerve a little bit more before continuing on. The fibular nerve is derived originally from the L4 to S1 nerve roots, travels through the lumbosacral plexus, and has contributions from the sciatic nerve. There's a fibular portion of the sciatic nerve which eventually becomes the common fibular nerve, and that fibular portion of the sciatic nerve innervates the short head of the biceps femoris. The common fibular nerve then differentiates into the deep fibular nerve and the superficial fibular nerve. The deep fibular nerve innervates the muscles listed here and provides a small amount of sensation to the foot in the first dorsal webbed space. The action of these muscles is primarily with ankle dorsiflexion. The superficial fibular nerve innervates fibularis longus and brevis and provides a larger sensory distribution to the lateral aspect of the leg and the dorsum of the foot. The primary action of these muscles is ankle eversion. Classically, fibular neuropathy presents with both branches of the fibular nerve affected, superficial and deep. And there's typically weakness with eversion and dorsiflexion at the ankle, and there's sparing of the ankle inverters, which can help differentiate from an L5 or DIC. There's weakness that may cause a slap foot, falls or difficulty with gait, and compensated gait is a steppage gait. Sensory changes are located along the lateral aspect of the leg and the dorsum of the foot. Fibular neuropathy is compressive in nature by trauma, repetitive action, or by mass occupying lesion. Classic stories that patients tell frequently include crossing of the legs, weight loss, subacute or chronic, and prolonged bending at the knee, particularly with occupations, as well as poorly applied cast or high compressive boots. Current AANEM guidelines recommend a certain set of nerve conduction studies when fibular neuropathy is suspected. These tests include deep fibular motor studies to tibialis anterior, extensor digitorum brevis, as well as a superficial fibular sensory study. Additionally, they recommend completing another motor and sensory study of the same limb to further differentiate possible diagnoses such as peripheral neuropathy or radiculopathy. For our examination, we chose tibial motor with Cheater F, bilateral H reflex, and a sural sensory study. The three fibular tests in these guidelines aren't as frequently performed as other tests in MSU EMG labs. For reference and review, let's take a look at how these three fibular tests are performed. Motor nerve conduction study to the extensor digitorum brevis is completed by placing the active electrode over the midpoint of the extensor digitorum brevis muscle on the dorsum of the foot. The reference electrode is placed slightly distal to the fifth metatarsal phalangeal joint, the MTP joint. The first recording site for EDB is found by measuring 8 centimeters proximal to the active electrode, slightly lateral to the tibialis anterior tendon. The second recording site is at the fibular head. Typically, the anode and cathode straddle the fibular head. The third recording site is approximately 8 to 10 centimeters proximal to the second recording spot in the popliteal fossa, and the cathode is placed just medial to the tendon of the biceps femoris. Next, let's review the technical performance of tibialis anterior in a motor nerve conduction study. To start, measure the total distance from the lateral malleolus to the tibialis tuberosity. Divide this distance into thirds and place the active electrode in the first third along the tibialis anterior muscle. Next, place the reference electrode halfway between the tibial tuberosity and the lateral malleolus. The stimulator placement sites are exactly the same as with EDB, placed at the fibular head and in the popliteal fossa. In regards to the technical aspects of the superficial fibular sensory nerve conduction study tests, let's take a look at a 2016 paper that was completed by the Michigan State University faculty, which includes Dr. Safarian, Dr. Condi, Dr. Sylvain, and Dr. Andery, to name a few. This study looked at 4 different nerve conduction study tests to evaluate the superficial fibular sensory nerve. These 4 different techniques included the Spartan technique, which was a new technique obviously founded here, which hadn't been compared traditionally to other techniques, which included 2 different ISO techniques and the Daub technique. This study took a total of 108 healthy volunteers and utilized a total of 164 legs to evaluate these 4 different techniques against one another. Each subject was subjected to all 4 different techniques. This study found that all 4 techniques were reliable methods for obtaining superficial fibular nerve snaps and proved that the Spartan technique could go toe-to-toe with other techniques previously documented in other textbooks. Let's review some of the technical aspects specifically in regards to the Spartan technique and the medial ISO technique. These 2 tests are what I've seen most frequently used at MSU EMG labs. The Spartan technique is depicted here. The bar electrode is placed between the first and second metatarsals, 4 to 5 centimeters distal to the inframalleolar line. The stimulator is placed 14 centimeters proximally along the anterior edge of the fibula. The ISO medial technique is slightly different from the Spartan technique. The bar electrode is placed between the malleoli on the dorsum of the foot, just lateral to the extensor hallucis longus tendon. The stimulator is again placed 14 centimeters proximal from the recording electrode along the anterolateral aspect of the leg. Now that we've had a very thorough review of the technical approach to nerve conduction studies when the leading differential diagnosis is fibular neuropathy, let's return back to our case. Dr. Andery and I started with 3 main fibular nerve conduction study tests: tibialis anterior, extensor digitorum brevis, and superficial sensory study using the Spartan technique. We also completed a tibial motor test with a Cheater F-wave, unilateral sural sensory study, in addition to bilateral H reflex studies. These nerve conduction study tests were all normal for this patient. Following the nerve conduction study tests, we moved on to needle EMG. A comprehensive needle EMG evaluation was completed of the left lower extremity, which included needle sticks of 4 fibular nerve muscles. No abnormalities were seen on needle EMG.
So if you're still with me here, you're probably saying, well, what the heck, Hake? You said this is going to be an interesting case, and all you've shown us is some important technical details in a normal study. But this is where the case starts to get interesting. Dr. Andery and I had completed the EMG in the exact order that we presented here. We were left reviewing the results and debating sending the patient home with a normal EMG study with clinical signs suspicious for fibular neuropathy. Dr. Andery and I discussed an additional nerve conduction study test for further evaluation of the superficial fibular nerve, a test outside of the AANEM guidelines or recommendations, a motor evaluation of fibularis longus. It was a test I had never completed before, and we weren't satisfied with our normal EMG results given the clinical picture. I then went out to complete a study that I had never done before, a fibularis longus motor nerve conduction study test.
The last nerve conduction study test that I'll describe today is the fibularis longus motor nerve conduction study test. The setup begins by measuring the total distance from the fibular head to the lateral malleoli. This distance is then multiplied times 2/5. The active disc electrode is placed this 2/5 distance from the fibular head along the fibularis longus muscle. This is multiplied times 3/5 for the placement of the reference electrode along the same trajectory. The stimulator is placed at the fibular head and in the popliteal fossa, just as it was before in the multiple previous studies. Finally, some abnormal results. Here, you can see that distal to the fibular head, the amplitude is 13.3. However, proximal to the fibular head, there's a significant amplitude drop. This amplitude drop suggests conduction block of the superficial fibular nerve at the fibular head.
At first, Dr. Andre didn't believe that I completed the test correctly, which is fair. We both went back to perform a technique called inching, and we were both bewildered to find that there truly was conduction block isolated only to this nerve conduction study test. Inching is a technique which involves multiple stimulations while slowly moving the probe along the fibular nerve at the fibular head. This inching technique showed that the exact location of the lesion causing conduction block was at the fibular head. Because this inching technique was utilized, a second confirmatory test was no longer required. We had found an isolated superficial fibular neuropathy.
So what do these results mean? Let's look to the EMG report for further understanding and interpretation of this case. Our findings included a singular abnormal test of the left superficial fibular motor conduction study to fibularis longus, which was confirmed with inching. All other tests were normal, including the superficial fibular sensory, which is peculiar. We'll return back to that in a second. Our conclusions from these findings are that there is evidence of a left superficial fibular neuropathy at the fibular head, and the injury appears to be neuropraxic without axon loss. We know that this injury is neuropraxic because we saw an amplitude drop across the fibular head, and we know there is no axon loss because we found no fibrillations on needle EMG. Because this injury was neuropraxic in nature, we were able to tell the patient that there is a good chance that his symptoms could improve in the next 2 to 6 months. The etiology of this nerve injury was likely related to occupational knee positioning, but was not definitively related. If symptoms didn't improve with activity modification, more workup may be needed. Returning to a peculiarity of this case, we found an abnormal motor study with a normal sensory study to the same nerve, which is abnormal. A possible explanation for this is fascicular redistribution. Within one nerve, there are many fascicles, and some of these fascicles will have motor involvement and some with sensory involvement. In this case, there may have been neuropraxia preferentially affecting the motor fascicles. Another possible explanation for why we found motor involvement without sensory involvement is that we didn't completely examine the sensory portion of the superficial fibular nerve to the best of our ability. Dr. Andre and I were talking about that this week. We potentially could have performed other non-traditional sensory tests that may or may not have helped with further workup. There are a few things that I learned in particular from this case. First, I gained a better understanding of how to technically perform multiple fibular nerve conduction study tests. Secondly, this case shows that more tests may be beneficial to a patient's electrodiagnostic workup. On the contrary, it's important to recognize that more nerve conduction study tests would be painful for patients and would cost providers more time to complete testing and may not also provide more information to physicians and patients, depending on the case. Additionally, fascicular redistribution may explain differences in motor and sensory studies in specific cases of conduction block. Specifically for this patient, he was able to receive a definitive diagnosis that affirmed his symptoms and was given a prognosis and treatment plan accordingly. Thorough knowledge of EMG and anatomy, coupled with proper history and physical examination skills, best equip a provider to make better medical decisions and benefit patients. A special thank you to our foot models turned physicians, Drs. Vodapalli, Gilmore, and Safarian. Also, special thank you to Dr. Andre for assistance with his presentation. Dr. Andre was unavailable for peroneal posing. Here are my references. Go green! This weekend we will need all the luck we can get versus OSU. Have a great weekend.